Hello, Robert Bastian here with a discussion of atypical spasmodic dysphonia. Now, any discussion of atypical spasmodic dysphonia must begin with a recap of the typical features of spasmodic dysphonia, and so a recap. SD is a focal laryngeal dystonia, a neurologically based condition affecting voice production primarily. Common forms are the adductory variant. That's the most common. That's where the voice is squeezed and catches like that. And then the features are the strain and the strangled voice and the phonatory arrests, which are the cutouts or the catches or the grabs. And then there's abductory spasmodic dysphonia. The feature there is either a breathy voice like this or syllable dropouts to nothing, to air or to whisper. And of course, you could have a variant that has both adductory and abductory spasms. Now, both types can include dystonic vocal tremor, and typical but not universal characteristics are that SD is worse with stress and fatigue. It's worse in the chest register than it is in the falsetto. There's difficulty using the voice on phones or in noisy environments. It may improve with alcohol in many people, and the singing voice often works better than the speaking voice. And usually it does not affect breathing, that it's only phonation, making sound, usually. So atypical spasmodic dysphonia, there are some key variants. There's a variant that does what I call leading with tremor. And so when you speak to the person, you're hearing a voice that's dominated by tremor. So it's like, long ago, people found that it was easier to travel on water than on land. So you're hearing the shaking in the voice. And the pitfall in the diagnostic process and the protection from it is that you're listening for spasms. So you may hear almost all wavering. Long ago, people found that it was easier to travel on water than on land. But you have to listen for the little catch. So let me put in a few. Long ago, people found that it was easier to travel on water than on land. So do you hear those little spasms? Well, when a person leads with tremor, sometimes people overlook those infrequent and even subtle catches. So also they may overlook the dystonic features of the tremor. There's variability of tremor frequency. You can hear a so the speed, the frequency is varying, and the amplitude. So they may do one phonation that's and then for a few seconds they may kind of go where it's a shorter amplitude, and also task-related changes. So the risk when you're dealing with a atypical spasmodic dysphonia, meaning leading with tremor kind of a variant, is that you overlook the intermittent spasm, the strain, or the whispers, leading to a misdiagnosis. You say this person has a central tremor, when actually they have spasmodic dysphonia with an overwhelming tremor component. That distinction is critical to make. Another atypical variant is what I call the tonic variant of adductory spasmodic dysphonia. Years ago, I was at a big meeting at the NIH, and the group of experts was to define what's necessary to make a diagnosis. And a couple of the people on the panel said, oh, you have to have phonatory arrest, you have to have dropouts, cutting of the voice. And I raised my hand and said, no, that's not true. You can have dystonia, laryngeal dystonia, spasmodic dysphonia with no phonatory arrests. So the presentation there is continuous tightness and strain, but no obvious phonatory arrests. So I'll give you three types of tonic variant. One is where you just hear the voice like this. This is what I call non-dysphonic tonic variant, meaning you don't hear gravel and you don't hear any catches. It's just the voice is, pardon me, the voice is kind of tight like this. So that's one variant. Another variant is the chronic fry. It's the long ago people found that it was easier to travel on water than on land. You hear the strain is continuous, but you don't hear any phonatory arrests. And then there's even one that's what I call the stage whisper variant, where you hear the very tight voice like this and you don't hear any phonatory arrests. And people sometimes diagnose that incorrectly as abductor because they hear the whispery quality, but they neglect the stage whispery part of it, the squeezing. It's not a whisper like this, but it's a whisper like this. So the confusion there is that may be misdiagnosed as functional using the non-specific diagnosis of muscle tension dysphonia. It's really regrettable that the term muscle tension dysphonia has invaded the spasmodic dysphonia world to just great confusion, when really we should be talking about tonic variant adductory spasmodic dysphonia. So again, in the history of spasmodic dysphonia, expert opinion at one point said phonatory arrests are required for diagnosis, and that led to misclassification and delays. Another variant is the person who says, no, actually, my voice is better when I talk on the telephone. So I would say overwhelmingly people do not like the telephone. They often say, oh, I hate the telephone. And they say, drive up windows. And so in this variant, the patient says, no, the telephone is actually easier for me. And so that can confuse the examiner if one doesn't recognize that every typical feature, every rule of spasmodic dysphonia is broken by somebody. And so there's that confusion point, is that the very rare, I'd say fewer than 1 in 250 cases, find the telephone is easier, whereas 249 say, no, the telephone is harder. So the risk is that the clinician may dismiss the SD diagnosis in favor of a functional diagnosis due to this inverted pattern of phone working better rather than worse. Here's another atypical variant where singing voice is worse than speaking. The presentation of that is speaking is intact. I've had a few people out of my perhaps 1,500 lifetime or career-long series. I've had a few, maybe 5 or 6, who came to me with what sounded like a completely normal or nearly normal speaking voice. A couple of them were absolutely normal. There was nothing in the speaking voice, and they said that too. No, I don't ever notice anything in my speaking voice. But once we had them sing, especially above what's called the primo passaggio, the chest register break, usually just above middle C, the voice became bizarre and severely impaired, of sort of doing weird glitchy things, grabbing and going to the wrong pitch and wavering and wobbling and so forth. So the confusion point there is this is the opposite of typical SD, where singing is often preserved or much better than speaking. And so the risk of encountering this atypical patient is that it may lead to a functional misdiagnosis. In other words, well, because singing is the only problem, that I don't ever see that in SD, so I think this must be a functional or even psychogenic problem, when in actuality there is an atypical expression of SD that is singing voice predominant. The last one that I want to talk about is what I call pitch register spasmodic dysphonia. In this one, the presentation is that the voice breaks between chest and falsetto without classic adduction or abduction features. And so the person is trying to speak to me and they're completely sincere and they're trying very hard, but the voice is constantly kind of cracking up into falsetto. And the mechanism suggestion is that there may be possible active spasms in the cricothyroid muscles. That's the singer's muscle that helps us get to high pitch, combined with a kind of intermittent flaccidity, almost like a flaccidity spasm, like the muscle going to limp instead of to contraction in the thyroarytenoid muscles. And since this is rare, I've seen, I think, 2 cases of this out of my 1,500, where the person was extremely troubled because the voice was constantly cracking into falsetto like that. This may be misdiagnosed as functional or stress related. oh, I have one more, and that is spasmodic dysphonia, which is the phonatory expression, the voice-making expression, combined with respiratory dystonia. And respiratory dystonia, I sometimes call it segmented breathing. So the presentation is that spasms interfere with inspiratory or expiratory flow, or both. And it creates a choppy breath pattern. So if I mimic, instead of a like that where it's a long swoosh in of air, it becomes a, and I'm exaggerating, a kind of a so rather than a smooth inspiration, it's cut into little pieces by these spasms that are segmenting the inspiratory flow, or it can be involuntary breath holding. I breathe in, and then when I want to breathe out, it goes out in little pieces. It's kind of a so the confusion point is when this is seen alone, it's not a classic phonatory issue, but rather dystonia affecting respiration. And so the risk is it can be mistaken for asthma or paradoxical vocal cord motion, or even a non-organic or psychogenic disorder. And I've seen people who go through extensive unnecessary pulmonary consultation and testing. So misdiagnosis is common in atypical SD, often as muscle tension dysphonia due to unfamiliarity with tonic variant SD. Essential tremor could be the misdiagnosis due to poor recognition of occasional or even rare dystonic spasms, or not being able to differentiate between essential tremor phenomenology and dystonic tremor phenomenology. Or functional voice disorders can be misdiagnosed. Psychogenic voice loss could be the direction that doctors or speech pathologists take you, because you're an atypical SD. So the key for clinicians is to use task-specific assessments, speaking versus singing, reading versus conversation, even a little bit of trial therapy. You know, can you read it in this voice? How about if you read it in this voice? So you look to see dystonic features manifesting as both spasm, tremor, pitch register breaks, or tonic squeeze. The takeaway, atypical SD is still SD, just in partial disguise. And recognition depends on nuanced listening, careful vocal task elicitation and response analysis, and avoiding over-reliance on classic features like phonatory arrest or speaking-only dysfunction. Well, thank you very much for listening.